Good
Good
evening,
evening.
Jamila. You're welcome.
Thank
Once
you. It's nice to be here. Okay, my name is Jamila Sani, Pharmacist Jamila Sani, and I want to have a little presentation on pharmacists' roles in hepatitis prevention, treatment, and advocacy. So this is my outline. Can you see the slides?
yes,
Hello?
I can
Yes, we
see
can.
the slides. Yes, we can see the slides.
Okay. So this is my outline. So by way of introduction, hepatitis is the inflammation of the liver, as we all know, which is caused by various factors, including viral infections, alcohol abuse, toxins, medications, and some autoimmune disorders. The condition can be mild, it can be severe, and it can be acute or chronic. Hepatitis B can cause a chronic infection and puts high people at risk, people at high risk of death, cirrhosis and liver cancer. Epidemiology. WHO estimates that 254 million people were living with chronic hepatitis B infection in the year 2022, with 1.2 million new infections each year. And in 2022, hepatitis B resulted in an estimated 1.1 million deaths, mostly from cirrhosis and hepatocellular carcinoma, which is primary liver cancer. In Africa, including Nigeria, hepatitis is a silent epidemic. More than 90 million people are living with hepatitis, accounting for 26% of the global trend, which is a significant number. Nigeria has a prevalence rate of 8.1 and 1.1% of hepatitis B virus and hepatitis C virus among adults aged 15 to 64 years of age, respectively. So types of viral hepatitis. As we all know, we have hepatitis A to C, hepatitis A, B, C, D, and E, which are all different in their modes of transmission, in their severity of disease, and even in their treatments. So we are going to see how different they are from each other here. So for hepatitis A now, the source of infection is usually contaminated food and water, usually fecal oral infection. That is where the hepatitis A is gotten. And the type of infection for hepatitis A is an acute infection. It does not cause chronic infection. Diagnostic parameters are usually presence of antibodies for hepatitis A virus. Usually treatment for hepatitis A virus is just supportive. Hydration, rest, that's all, and it goes on its own. Then for prevention, if you want to prevent hepatitis A, you need to inculcate the habit of good hand hygiene, washing of the hands regularly, and also there is vaccine available for hepatitis A virus. Also, there is the immunoglobulins available for hepatitis A virus. For hepatitis B virus, it is mainly gotten from body fluids, from blood, during blood transfusion, that's an infected blood, body fluids like semen, vaginal fluids, amniotic fluids, saliva, during sexual intercourse, unprotected sexual intercourse, you can have a hepatitis B infection, and also people that abuse drugs. Also, a mother can pass it to her child during delivery. But hepatitis B virus is one of the most common and most dangerous type of hepatitis. It can cause an acute infection. It can also cause a chronic infection. Usually, chronic infection is when there is persistence of the hepatitis B antigen in the system for greater than 6 months. That's when you see that a person has chronic hepatitis B infection. For diagnosis, antibodies for hepatitis B virus show that someone has hepatitis, also if the person has an antigen of hepatitis B virus, that means the person is still infectious. If the person has the antigen, the person is infectious, he can infect other people. If the person has antibodies, it means the person has is now covered. The person is covered from giving other people the infection. So treatment for treating acute hepatitis B virus is just supportive, rest, supportive, hydration, and others. But for chronic infection, you need to do the interferon, the antivirals, and we'll go to that much later. Also, you can do well to inculcate the habit of hand hygiene. Vaccines are available for hepatitis B virus. Also, the immunoglobulins are available for post-exposure prophylaxis. For hepatitis C virus, it is mainly gotten via IV drugs. That's the drug abusers, people that are addicts, that mainly inject. They share, most of them share needles. They will inject and use the same needle for the other person to inject. So hepatitis C virus is gotten mainly via that. Also unsafe medical practices, also blood transfusions that are not screened well. It's less commonly gotten via unprotected sexual intercourse. Type of infection is usually acute and most of it turn chronic. Also, for diagnosis, you need to find the antibodies for hepatitis C virus in the person's blood. Treatment is usually the direct-acting antivirals, also the interferons. There is no vaccine available for hepatitis C virus, and also there is no immunoglobulins available. So, hepatitis D virus can be gotten via blood and body fluids, but hepatitis D virus cannot be gotten unless a person has initially gotten hepatitis B infection. So that means hepatitis B virus is the initiator of hepatitis D virus. Type of infection is acute and chronic, and diagnostic parameters, antibodies for hepatitis D virus. Treatment is usually with pegylated interferon. Prevention is usually to prevent hepatitis B infection by receiving the vaccine. That is how you prevent hepatitis D infection. Hepatitis C infection, it is almost the same thing as hepatitis A. It's gotten via contaminated food and water, also undercooked pork and wild games. Type of infection is also acute, just like in hepatitis A, but complications might arise in third trimester of pregnancy, where pregnant women usually have acute liver failure. So one needs to take care of that. Diagnosis is usually by the presence of antibodies for hepatitis E virus. Treatment is usually supportive and rest. Prevention is via hand hygiene, safe food practices, and safe water. Non-viral hepatitis. We have the alcoholic hepatitis, autoimmune. Alcoholic is usually due to alcohol consumption. Autoimmune is usually due to the body's immune system attacking the liver cells, as I said earlier, and the drug-induced hepatitis. And also we have metabolic hepatitis, which is caused by usually obesity and metabolic syndrome. That's the example, the non-alcoholic fatty liver disease and the non-alcoholic steatohepatitis. So there are phases in which hepatitis infection occurs. We have the prodrome phase. The prodrome phase is the phase in which the patient experiences fatigue, malaise, low-grade fever, nausea, vomiting, aversion to food, mild itching, joint and muscle pain lasting a few days. We also have the icteric phase. The icteric phase is the jaundice phase. The jaundice phase is where there is yellowing of the eyes and yellowing of the skin. There is also presence of dark urine and light colored stools, usually like clay colored stools, due to absence of bilirubin in them. So prodromal symptoms improve, last a few days to weeks, usually less than 6 weeks. And then there's the convalescence, that's the gradual recovery phase.
Choose the button. Oh, okay.
Symptoms of hepatitis. The symptoms of hepatitis can vary depending on the cause and severity, but please excuse me, sorry.
While we wait for our hosts, we want to thank those that just recently joined us. Josephine, welcome, ma. Thank you
Sorry,
for joining us. Okay, she's back.
sorry.
Thank you. No problem.
So diagnosis of hepatitis. In order to diagnose hepatitis, there's a combination of medical history, physical examination of the patient, and laboratory tests that need to be carried out. But blood tests, we detect liver enzymes. Usually, this otherwise known as the liver function test, the AST, ALT, ALP, usually they tend to increase when one has hepatitis. Serum proteins, bilirubin, they all increase. Prothrombin time, international normalized ratio are usually high when one has infection with hepatitis. And also the serological tests that show the viral antigens and antibodies in the person's blood. We also have imaging studies like the ultrasound, CT scan. They check for they show any liver damage. That is in case of any fibrolysis or any issue with the damage with the liver. That is where they come in. We also have the liver biopsy that shows the extent of liver inflammation and fibrosis. So prevention of hepatitis B, since hepatitis B is one of the most common and one of the most severe, we decided to talk about the prevention, how it is prevented. So in Nigeria, there is a guideline. This guideline is for Nigeria that is currently being used. The current routine immunization schedule for infants includes 4 doses of hepatitis B vaccine. The first dose is a monovalent hepatitis B vaccine. That means the monovalent means it's only hepatitis vaccine that is there. It's given usually within the first 24 hours of life for an infant. Subsequent doses of the vaccines are given as a component of pentavalent vaccine. It's given at 6 weeks of the child's life, at 10 weeks, and then at 14 weeks. The pentavalent vaccine usually covers for diphtheria, pertussis, tetanus, hepatitis B, and also Haemophilus influenza type B. So this is just a tabular form of how it is given. 0.5 ml, that's the dosing. Then it is mostly given IM, intramuscular. So how do you prevent mother-to-child transmission of hepatitis B infection? The recommended practice to reduce mother-to-child perinatal transmission relies on the administration of hepatitis B vaccine and concurrent administration of hepatitis B immunoglobulin. We all know that vaccines are different from immunoglobulins. Vaccines usually provide long-term immunity, while immunoglobulins provide, their immunity is usually fast, rapid. So that is why it is given when one is exposed. You give them immunoglobulin so that it will act fast, but the immunity is short-termed. It's short-termed. So that is why a patient now should be given hepatitis B vaccine concurrently with the immunoglobulin. Also, the administration of nucleoside analog to the hepatitis B virus infected pregnant women from their third trimester to delivery. That's from 28 weeks till when they deliver. That is when you give them that. All exposed babies born to patients positive hepatitis B antigen positive mothers should receive hepatitis B immunoglobulin intramuscularly in addition to the vaccine.
Making your online lecture.
So this immunoglobulin must be given within 24 hours of birth. So any woman that is infected with hepatitis and gives birth to a child, she must get that immunoglobulin on standby and give the baby within 24 hours of birth with the first dose of hepatitis B vaccine. The first dose that we talked about earlier, that is when on the same day, but the administration site should be different. Hepatitis B virus infected pregnant women with hepatitis B E antigen positivity should be treated with nucleoside analogs. So for hepatitis B virus infected pregnant women who are negative but have high viremia of like greater than 200,000 IU per mil, they should be treated with nucleoside analogs, example, the tenofovir lamivudine. Yes, the recommended drugs to be used from week 28 till delivery, as I said earlier. And entecavir is rarely used in pregnancy because the safety is not really understood, not known. So prevention of hepatitis B transmission in older children, adults, adolescents and adults. So in unvaccinated older children, that's children that have not been vaccinated earlier from 1 to 11 years, the recommended schedule is monovalent HPV vaccine. You take at 0 month, 1 month, then after 6 months, you're going to take 10 microgram per 0.5 ml, and it is via IM2. In previously unvaccinated adolescents and adults, the recommended schedule is monovalent HPV vaccine at 0, 1 at 6 months, but the dose is 20 microgram per 1 ml, IM2. Then, indication for immunization in these categories. All hepatitis B antigen negative individuals should be immunized. However, when antibodies of hepatitis B test is done and the titer value is greater than micro IU per mil, then vaccination is not required. That means the person is fully immunized. He already has immunity against it. So the person does not need to be vaccinated. Special populations. Persons who do not respond to the first series of hepatitis B vaccine should complete a second 3-dose vaccine series. You know, there are people that even after taking the first series, that's you've done 0 at 1 and at 63 doses, you still check their blood level, you see that they do not have the immunity against hepatitis B. So a second series is needed for those kind of people. And you follow the same schedule at 0 and 1 after 1 month, then after 6 months. For HIV patients, or patients that are undergoing hemodialysis and other immunocompromised individuals, it is recommended that the dose of vaccine should be doubled. That means they're taking 40 microgram per 2 ml, as against the normal 20 microgram per 1 ml that the normal other people are taking. And a fourth dose is also included in these special people. That means them they are taking at 0 after 1 month, after 2 months, then they'll still take after 6 months. Goals of therapy for hepatitis usually is to prevent progression of the disease, particularly to cirrhosis. Because when there is cirrhosis, we already know that it's going south. Liver failure, hepatocellular carcinoma. So we are preventing the progression of disease. Also to improve the quality of life of the patient, to achieve undetectable levels of hepatitis B virus, to achieve hepatitis B antigen seroconversion and development of antibodies. Because when there are antibodies against it, that means the person is fully immunized. Then there is also normalization of serum alanine transferase. That means it will be normal now instead of the high that it was during when the person was had maybe acute hepatitis. Then there will be loss of hepatitis B antigen, but there will be development of the antibodies against hepatitis B. So pharmacotherapy of hepatitis, as we said earlier, hepatitis A and E, they are self-limiting. So there is no particular treatment for them. It's just supportive. That's all. Hepatitis B and C, that's when you need antivirals. So for hepatitis B, you use the nucleoside analogs, where tenofovir, entecavir, lamivudine, adefovir, they are all examples of drugs that can be used. Entecavir and tenofovir are usually used as first line. Lamivudine is an older drug with a higher rate of resistance that is now less commonly used. Adefovir is less commonly used due to its lower potency and high rate of resistance compared to newer ones. Interferons are also used. Pegylated interferon is used. It enhances the immune response against hepatitis B virus. It is used less frequently due to its side effect and subcutaneous administration. It can achieve sustained virological response and is often used in younger patients and those without advanced liver disease. For hepatitis C virus, we use the direct acting antivirals, example grazoprevir. We also use the others like ledipasvir, velbatasvir, and prebentasvir. Also, sofosbuvir can be used for hepatitis C infection. Also, the interferons are used. Ribavirin is also used in treatment of hepatitis C infection, hepatitis C virus infection. For hepatitis D, we use the pegylated interferon alpha, which is currently the mainstay of treatment. Ongoing research aims to develop more effective therapies as pegylated interferon often has limited efficacy and significant side effects. As we said earlier, hepatitis A virus and hepatitis C are just for they just need supportive care. So latest findings show that there's a drug called recent advancements in the treatment of chronic hepatitis B include the US FDA granting fast track designation to a drug called bepirovirsen, which is an investigational antisense of oligonucleotide. So this drug, the phase 3 development of bepirovirsen has shown promising results in achieving a functional cure response, addressing an unmet medical need in chronic hepatitis B treatment. So we await the release of this drug. Roles of pharmacists in prevention and treatment of hepatitis. Pharmacists provide essential education to patients regarding hepatitis, including the nature of disease, modes of transmission, preventive measures, and the importance of vaccination. Inform patients about transmission, educating patients on how hepatitis virus are transmitted, e.g. via blood, body fluids, contaminated food. So when you inform the patients, it will help them. If they are not yet infected, they will be able to prevent themselves from getting infected. If they're infected, they'll be able to prevent their family members or any close relatives or colleagues at work prevent them from getting infected. And also vaccination education. We really need to to be more serious on vaccination education, because as it is, I think most people don't know that you can be vaccinated against hepatitis B, especially adults. They just feel that the vaccine is available for only infants. So when you educate people, not just the patient, people around you, you educate them that the vaccines are available. They should go and take their vaccination. It will help in um, preventing people from coming down with infections. Also, lifestyle modifications, counseling patients on lifestyle changes to reduce liver damage, such as avoiding alcohol. People that take alcohol, advise them that alcohol is very toxic to the liver, maintaining a healthy diet, and practicing safe sex using condoms, and uh, limiting yourself to one partner if possible. Medication management. Pharmacists ensure the appropriate use of antiviral medications. They manage drug interactions and monitor for adverse effects. They play a pivotal role in therapeutic recommendations. They assist in the selection of appropriate antiviral therapy based on the clinical guidelines. There are many clinical guidelines, there are many treatment guidelines for hepatitis um, that one can use um, to inform the healthcare team of to help them make an informed decision on which drug to give any patient that is suffering from hepatitis infection. Also, medication adherence. This is solely work of the pharmacist. The pharmacist that will improve adherence, he or she will implement strategies to improve adherence, such as medication synchronization, pill organizers, and reminder systems for the patient to help the patient adhere to their medication so that there won't be any relapse or there won't be any complications resulting from non-adherence. Monitoring adverse effects. Identifying and managing side effects of hepatitis medications, such as renal toxicity from tenofovir or flu-like symptoms from interferon. So the informed pharmacist needs to monitor these side effects. If after initiating the patient on these kind of drugs, the pharmacist is supposed to inform the patient that he might experience these side effects, and this is what he is supposed to do when he experiences them. At least if someone is educated, he will know what to do, rather than just experiencing the side effects and not knowing what to do. Some people will just discontinue the drug when that is not what we want. So adherence support, ensuring adherence to prescribed treatment regimens is crucial for the effective management of chronic hepatitis B and C. Pharmacists support adherence through patient counseling, educating patients about the importance of adhering to their medication regimen to prevent viral resistance and achieve sustained virological response. So, as we all know, part of our duties as pharmacists is to counsel patients. We counsel them, let them know, make them feel at home. They will tell us their fears, and tell them, we show empathy and tell them what to do. So when we educate our patients and when we talk to them, we counsel them, it even gives them a feeling uh, of togetherness. So they are likely to adhere to their medications when you counsel them and talk to them. Follow up. You conduct regular follow-up consultations to address barriers to adherence. This involves, you can get the person's phone number. The person is not an inpatient, or if you don't get to see the patient regularly, you can collect the person's phone number and you can just show your care. That's pharmaceutical care by talking to the patient, knowing how far. Are there any barriers to adherence? Is there anything that is making him not to adhere to the medication? Any side effects? Anything? So pharmacists need to follow up with their patients. Collaborative care. Pharmacists collaborate with other healthcare providers, They ensure a holistic approach to hepatitis management. Their collaborative roles include interdisciplinary communication, thus sharing patient information with physicians, nurses, and other healthcare team members, coordinate care and optimize treatment plans. Monitoring therapy, assisting in monitoring treatment response by reviewing lab results. Very important in hepatitis infection. You need to be reviewing the lab results from time to time, to be checking the viral load and checking the liver enzymes, that's liver function test, to see if they're still high or if there's any issue. They need to be monitored. So if there's no collaborative care, you can't be able to monitor that patient because you need the medical lab scientists to do this. So there is need for this collaborative care. Adjusting therapy, recommending adjustments to therapy based on patient response and emerging clinical evidence. So this one is just like individualizing patient therapy. If there's anything, the patient response is good, it's fine. If the patient's response to medication is not so good, you have to adjust it, maybe change the medication, maybe change the dosage, and due to emerging clinical evidence, you have more knowledge on how to treat patients. Preventive measures and screening. Pharmacists contribute to the prevention and early detection of hepatitis through screening programs. Participating in or organizing screening programs for at-risk populations. At-risk populations, they are the IV drug users or individuals with a history of unsafe sex practices. These are the sex workers, female sex workers. We also have the male sex workers, also men who have sex with men. They're all at risk of having hepatitis. So organizing a screening program for them will aid prevention of hepatitis infection. Also, vaccination campaigns, leading or supporting vaccination initiatives in the community to increase hepatitis A and B immunization rates. Also, pharmacists play a huge role here. They are supposed to lead vaccination campaigns, show people that, okay, vaccination is very important. You need to come out en masse, come and have your vaccinations so that you get protected against these infections. Since we only have vaccines right now for only hepatitis A and B. Public health education. Pharmacists are supposed to engage in public health campaigns to raise awareness about hepatitis and promote preventive behaviors. Yes, pharmacists are supposed to be health educators, especially, for example, hepatitis C is 10 times more infections than even HIV, but plenty people are not aware. So pharmacists here have the at liberty to educate people on how to prevent getting infected, educate them on how to stay clean, hand hygiene, food, how to get good food, how to prevent themselves from getting entangled in unsafe practices, unsafe sex practices. Also, they have to engage them in awareness, making them aware that sharing sharp objects is very harmful, and other stuff that might lead them to have a healthy life. So in conclusion, pharmacists play a crucial role in the management of hepatitis, particularly in patient education, medication management, and overall disease management. Their contributions help improve patient outcomes, enhance medication adherence, and support the healthcare team in providing comprehensive care. These are some of my references, and thank you for listening.
Thank you very much, Pharmacist Jamila, for this detailed presentation. It was really enlightening. You really gave us up-to-date information. Like, yeah, we might have some education for it, but it was really enlightening. I want to say thank you very much. So prior to you starting the presentation, because we didn't want to we wanted to start before people really join. I didn't get to properly introduce you. So for those of us that are here, our presenter is pharmacist Jamila Sani, and she's a lecturer of clinical pharmacy and pharmacy management at the Faculty of Pharmaceutical Sciences, Kaduna State University. She has her B.Pharm and her MSc in clinical pharmacy. Her PhD is in view, and we can see how detailed and how she's proving to us that she's doing well in researching, or she did well in researching the topic. She's a fellow of the Postgraduate College of Pharmacy, and she's a member of SIPAN and member of PSN. So thank you very much, Pharmacist Jamila. So now, I told our listeners to drop their questions in the chat. So for the people that have dropped, I'll ask. But please, if you have questions, if you have contributions, and if you just want to maybe give us a word of encouragement or come or share more information, you can request the mic and you ask. So from Jamila, let me ask the question. Or do you want to say something before I go on, presenter?
There are some questions here in the chat box.
Okay. So you just read them and answer them back. So I don't need to read. I was thinking maybe I'll read them,
Yes.
but just go ahead and address the questions. Thank you.
So this one says, my question is, how long does a patient need to take lamivudine or tenofovir for him to test negative after treatment? Can you hear me?
Clearly, I can hear you clearly.
Okay. So how long does a patient need to take lamivudine or tenofovir for him to be tested negative? Actually, from what I read, I don't know if there are other stuff. From what I read, you just need to, while you're taking it, you test like every 6 months. Once they see that their viral load is down, that is when you might need to stop or reduce the dose or do other stuff. But there isn't, especially when you're having a chronic infection. For chronic infection, you just need to be monitoring the liver enzymes, monitoring your antigens, making sure that everything is back to normal before you can now stop.
There's one before this one. There's
I'm
one
going up.
question.
This one said, since chronic infections are treated, what do you do during active infections? As I said, are there things to watch out for during active infections? Usually it's supportive. You just treat the symptoms as at that time. If the patient is suffering from nausea and vomiting, you treat the nausea and vomiting. If there's fever, you treat the fever. But the patient usually needs rest. Rest is one important thing during what's the word? During the active infections. So and good diet. Those are the things to watch out for during those kinds of infections. I think those are the questions. Ziri. Are there others?
We have some hands. We have two hands up. So if
Okay.
they
Please allow them.
unmute, right. Please, Sir Prince, can you unmute and ask your question? Thank you. Then we'll come to Sir Olubukola after Sir Prince. Thank you.
Okay, thank you very much, moderator. And let me also quickly appreciate Pharmacist Jamila for your wonderful presentation. Okay, and I will just go straight to mine. Is not a question, or I just have a few comments as regards some of the aspects of viral hepatitis. Let me start with the MTCT, mother to child transmission of viral hepatitis. So the new WHO guidelines for the elimination or prevention of mother to child transmission really is not amplifying the use of hepatitis B immunoglobulin. Okay, yes, that can come in resource where in settings where there's enough resources for that. But in LMICs, low and middle income countries, the priority is with the birth dose vaccine. So once the birth dose vaccine, because it has been shown that they are comparable, when the birth dose vaccine is administered within 24 hours to a child born to a seropositive mother, and then follow up with the other series at 6 in form of the pentavalent at 6, 10, and 14 weeks. That's sufficient to break transmission. We really don't have to be emphasizing on the hepatitis B immunoglobulin now, because first it's even very expensive. Okay, and one other aspect that we can really work around, because if you look at for instance, the hospital settings, you realize that the hepatitis B monovalent vaccine, for facilities that have the vaccines in-house, you realize that they are not really easily accessible. So as pharmacists, we can begin to champion that aspect, where possibly what we're even looking at now is the possibility of having some of these doses kept in the pharmacy, just as we have tetanus toxoid in the pharmacy. Now, because the global target is to have bed dose uptake of at least 90% by 2030. So one way we can work around that is to have this bed dose moved to the pharmacy, because the pharmacy runs 24/7. Then every woman that is going into labor, as we give the delivery pack or CS pack, as the case may be, we include the bed dose into that. And that way we can guarantee that every child that is born in the facility would get the bed dose within 24 hours. So talking about stability, I know there have been issues regarding stability of the vaccine. This vaccine is one of the most stable vaccines in the world. So it can be very stable even at room temperatures. So the issue of stability should not be a problem there. Okay, so that's one way pharmacists can begin to function, okay, to ensure that children get this bed dose within 24 hours. So that bed dose is very critical in preventing mother-to-child transmission. If we miss that bed dose, children who are born to positive mothers may become positive even before they receive the first dose. And we've seen cases like that too. Okay, so that's one aspect. Then the other aspects that has to do with treatment using the current now based on the current guidelines, the mainstay for management of hepatitis B is the first line is the tenofovir. But because of convenience, for reasons, one of the reasons why the lamivudine is coming into the picture because in the HIV programming we have fixed dose combinations, and so WHO is trying to integrate services into the HIV platforms, where we can now have funding, through the PEPFAR and Global Fund, to assess tenofovir in that regard. But tenofovir alone is the drug of choice, and for management of hepatitis B. For pregnant women, now they've even gone further to now say every pregnant woman. Because if you look at the current treatment guide algorithm for PMTCT, you will see now that it's now even more expanded, such that even at least 50% of those who were not covered under the criteria for treatment are now covered. Now, the goal is really to test and treat, but because of the issue of funding, no funding for viral hepatitis at the moment. Okay, so patients still pay out of the pocket to get treatment. So that is the reason why that aspect of, okay, still now look at some criteria. But at the moment, one thing that is now hanging for Africans or low or LMIC is that you really don't have to do viral load for pregnant women. Once you do the surface antigen and it's positive, commence treatment even from the second week of pregnancy. So that's now the direction, and that saves a lot of costs. And tenofovir, of course, in the HIV programming, we know that it's safe in all trimesters. So it really doesn't matter at what point. But from second, it used to be 28 weeks, but now I think they stepped it a little bit to now say from second trimester. But if we do from the 28 weeks, it's still very okay. But the point now is that before now, we used to rely on the viral load or e-antigen, which are, in any case, not really available in our facilities. So now, any positive pregnant person or woman you identify, as a pharmacist, we must ensure that these women are placed on tenofovir. And the form of it, the short form is the tenofovir disoposite fumarate, as you rightly said. The TAF alafenamide, we really don't know how that would, affect the pregnancy at the moment. No, not much studies have been done on that, in that regard. So the TDF is very, very important. Okay, so but the question again is, how many of our facilities have tenofovir available? That's a very big problem. And so now from the NASCAP, from NASCAP, we've had some interactions, and then we're looking at, because the global WHO direction is integrating services. So, but countries are still now finding it difficult to adopt the public health approach to integrate services in, where viral hepatitis can easily align with HIV programs. But because of funding, again, those who are funding are still very strict. Like the PEPFAR are very strict in funding for HIV. So all that needs to be ironed out. But for now, as long as the woman is positive tester, treats, that's the direction. And I think somebody asked a question, for how long would this treatment continue? Now, for non-pregnant person, as long as you commence treatment is for life. Because for now, we have not recorded issues of resistance with the tenofovir. It has for now. So we've seen also situations where people stop, and then there is what we call flare, viral hepatitis flare, and which can be very, very fatal. So anyone who begins treatment must stay on treatment lifelong. Now, we talked about the use of, for one of the goals of treatments is to have some kind of seroconversion. But the truth is, the current nukes that we have, the nucleotides, cannot help us get seroconversion. That is the reason why GSK is now working on the bepirovirsen. And that bepirovirsen, which is the antisense oligonucleotide, it is from the the FDA just gave the accelerated approval because it's seen to now be able to help achieve what we call that functional cure. Because at the moment, hepatitis B is a very complex virus. Once it gets into the liver, it forms that form, what we call the cccDNA, close secular covalent DNA. And that is the bane of the problem of therapy. None of our nukes can get to that cccDNA. And the cccDNA is not cytoplasmic, it's intranuclear. And TDF can't go into the nucleus. And that's a problem. So the vaccine has shown good prospects, yes, but at best can only help us get that functional cure where the hepatitis B surface antigen would not be seen anymore. But the core antibody will still be there, but surface antigen will not be seen because the vaccine will be able to now put some kind of control of the virus. Okay, but for the current nukes, it's not likely. In fact, the proportion, maybe less than 1% may achieve that, maybe after like 10 years, at least 10 years. So it's difficult. So the goal now is, the goal of therapy is actually to put the virus under control when we are using the nukes. Okay, so that's just for that. Then I think, sorry, I'm taking too much time. I don't know if I should stop at the moment.
Let's continue, sir.
Okay, so I just wanted to point out something about the hepatitis C. Now, if I may ask, how many of our facilities have hepatitis via declatas via? That's the problem again. So people who are diagnosed with hepatitis C and in our facilities, say we're working in the hospital or even the community pharmacy, when they're diagnosed and we don't have this medication, what happens? That's a big lacuna, which as pharmacists, we are supposed to fill up that lacuna. Our primary goal is, our primary responsibility is to make these drugs available. So if they're not available, then what happens? So folks via declatas via, we hardly see them in our facilities. That's an issue. And then I just wanted to talk about the hepatitis C before the initiation of the SOFDAC. Normally for hepatitis B, we check for the surface antigen, but for hepatitis C, usually the antibodies we look out for. Now, the presence of the antibody for hepatitis C does not presuppose that this person has an active infection. That's another thing. So we can, as pharmacists, begin to educate even physicians too, that yes, not because the person just tests positive to the hepatitis C antibody, then we have to place the person on SOFDAC or any of these DAs. We need to now do that's where viral load is very important for hepatitis C. We must check for the RNA. The presence of RNA confirms that there is hepatitis C viral infection. And that in that situation, that person must be placed on PAs for 3 months. For some, about 98% will get cured, what we call sustained virological response. Some, like 2%, may not be able to, and they will have to repeat that course of therapy for the next 3 months again. So between 3 to 6 months, and we can have 100% cure. So there's cure for C, but for B, treatment is lifelong. Thank you very much. Sorry for taking this long.
Thank you, sir. Thank you so much.
Thank you very much. That was a nice one. Ma Olubukola, can you go on? Thank you.
Thank you very much. Good evening. I hope I'm audible.
Yes, you are. Good evening, ma.
Okay, so I also want to join to appreciate Pharmacist Jamila for that wonderful presentation. Hepatitis is one area that looks like you don't get so much information about, and I think the wrong perception to think that we don't have much of it around. I used to work in a maternity center in Oyo State, and the rate of women who were at antenatal who were testing positive to hepatitis were getting alarming, and that's something that points to that they need to address hepatitis. So to my question, actually, the last speaker actually addressed like two areas of the things I wanted to raise, because like I said, I work in a maternity center. And for women who who are diagnosed to be hepatitis reactive during pregnancy, you see that they are forced to start saving money right from before they give birth to procure immunoglobulin injection for their babies, And then sometimes, in fact, after birth, if they don't have money, they are running around. And, during the lecture, I know Pharmacist Jamila had said that they have to take it within 24 hours. I know in my hospital, then they still give them this allowance of 72 hours. And most times during that time, mothers are usually not encouraged to breastfeed, their babies until they are able to take the injection. But I'm happy hearing the last speaker talk about, the bedside in is it the monovalent injection? I try to hear it very well. That babies can take it, and it's cheaper, and of course it doesn't need so much of a cold chain. That's really interesting, and I think there is need for a lot of awareness creation, especially in hospitals that are maternity, where you have a lot of pregnant women who might be giving back to, who might be reacting to hepatitis and giving back to babies. So, as pharmacists, there's need to be part of that awareness creation, especially introducing this low cost, injection that can help babies. So, secondly, so that's why I said when he was talking, he actually addressed some of the concerns I have. And secondly, is also access to the injections, to the tablets that are used for treatment, because being in the hospital, a lot of times patients are prescribed tenofovir, entecavir, and they are looking all around. They get to pharmacies, they are told to pay. They are going to make special orders for their drugs and all that. So that makes treatment a little bit difficult for patients, and as pharmacists, we get a little bit handicapped in recommending appropriate place where they can get this from. So some of the responses he gave are quite insightful. What I want to say is, what is the place of herbal treatment in hepatitis? Because along this line too, with my experience, I've seen instances where when patients get frustrated because of access to drugs, I've seen people who recommend alternative medicine. And believe you me, they have come back to record low viral load. They have really come back because the people who are doing it are people who are learned and who try to show evidence that what they are administering is working. So they get patients who have high viral load initially, and after I think 3 months or 6 months treatment or so, they have a low viral load. So I don't know if there's any experience with herbal medication, in the treatments of hepatitis. Thank you. That's just my
Thank you. Thank you, ma'am.
All right, thank you very much, Ma. Very beautiful, wonderful point. From Jamila, please can you address her last part, because that's my place
Point
of
of
interest before I
herbal
come in.
medications. Use of
Yes.
herbal medications in treating hepatitis.
Yes.
I feel like she just said that she has had experiences where people come back and the viral load is down. This is up to our regulatory agencies that regulate complementary and herbal medications. If those medicines work, why not? They should they should do clinical trials and all stuff they're supposed to do and bring the drugs to us. That is what we need. We need all these drugs to help our patients. I think it's up to our agencies to do that so that
Okay.
the patients will be at peace with what they're taking. That's
All
what I
right.
feel.
Thank you very much. So I'll comment on that. Then I'll ask Mr. Prince a question. Then I'll give my contribution. Then we'll proceed. Like here in Kaduna, in my community, I've heard of people using the karkashi plant. That's the Hausa name. I was trying to rush and see if I could get the English name or other names, but so like I've heard that people have said, but I've not done any research work on it, and maybe I'll look to see. And I think the important thing from that is in the contribution we saw how Pharmacist Prince kept saying we don't have resources, we don't have resources. You know, the HIV program, we know we've been doing well because of partner and donor funds, you know, and we're even still now looking up to partners and donors to like really try to curb hepatitis, you know. So it's really sad that, you know, with the state of our economy, like we can't handle certain things. So yes, while we try to improve our economy and try to provide as in drugs, we should also maybe look at other options, which is like the alternative and complementary medicine. We already have a research institute. We have the NAM, is it Nigerian alternative? I can't remember the full meaning, but they also look into alternative drugs. So we can work on our own drugs because we can see in certain areas that has been done and we have gotten things that or drugs that can help. So that's just for alternative and or the herbal medicines. So I'll leave it at that. My question for Pharmacist Prince is, you came and you said, okay, based on so far, Jamila, this is where practice and or practicals and theory, academia and practice have a little clash, you know. You give us the ideal. Then he comes and he says, oh, now we feel this is sufficient because we don't have funds. So my question to Pharmacist Prince is, let's assume hypothetically, let's assume that we have funds, or let's say somebody has the resources to get these drugs. What is the ideal thing to do in the prevention of the mother to child transmission? If somebody can source the drugs, what should be the ideal thing? Should they give the monovalent vaccine on that very day, the 24-hour period after birth? And should they still administer the immunoglobulin? Because I just want, we need that information. So please, can you answer my question if you can hear me?
Okay, okay, thank you very much. So, yes, the first thing is let's get it clear that both the hepatitis B immunoglobulin and the monovalent bed dose can be administered same time within 24 hours. So they are given on lateral sides, either sides of the leg of the lateral side of the child. Okay, so both the immunoglobulin and the bed dose can be given the same time. But the focus here is now, because in China there was this study that was done to compare the effectiveness of the hepatitis B immunoglobulin B when given alone, and also compared with hepatitis B immunoglobulin plus the bed dose, then also compared with hepatitis B monovalent bed dose alone. So they were found to be it was for the report from that showed that both the group that were given the birth dose were within 24 hours alone were comparable. Okay, that group was comparable with a group that was given both birth dose and immunoglobulin together. In fact, that informed the WHO now to now start looking at this direction. If you look at the guidelines closely for prevention of mother-to-child transmission, you will see clearly that the WHO did not talk about the immunoglobulin, but only mentioned it as a rider under where it was put as if available. So this was, for WHO to come up with guidelines, it follows a lot of tough scientific debates. From they do meta-analysis and then look at evidence. It's evidence-based. So that is the direction now. And there's no issue really with if a pregnant woman can afford immunoglobulin, fine, no problem. But the point is, if it's not available, there's still no problem. Just administer the birth dose, and the birth dose is free for every child. But the only challenge now is whether it's readily available. That's where we should now start coming in as pharmacists. Because if you observe that vaccinations are not done every day. In facilities, you see vaccinations are done on scheduled days, like maybe some will say every Mondays, some say every Tuesday or like that. What about weekend? Now, a child that is born outside any of these
When
days,
I finish, come back.
what happens? So that's why like for me in Delta states, I practice.
Sorry if I'm Prince. Can you unmute? It's like someone else was talking.
Oh, sorry about that. So we should, as pharmacists, educate these midwives that birth dose is very timely. So we should not focus on the immunoglobulin anymore. That is what points at some the instances where we can now prioritize immunoglobulin B are situations of eventful delivery or forceps delivery, and where we know that the viral load of this woman, maybe a woman who just rushed into the hospital and she's in labor, and then prior investigation, blood work showed that she's positive. So we really don't have time to now determine her viral load. So that situation here, we can see if we can now initiate the immunoglobulin along also with the birth dose for this child. But if this woman is known, receives antenatal care in that facility, and she's on antiviral prophylaxis, there's no point really bringing in the immunoglobulin B. Just ensure that the child gets his birth dose when the child is born within 24 hours. That is very sufficient to prevent mother-to-child transmission. Thank you.
All right, thank you very much. All right, thank you. So, with regards, I think this just goes to, because the topic was our roles in prevention, in treatment. It also like buttresses the fact that we have to do much of patient education. We really have to do that to ensure that we tell them prevention is better than cure and resources are tight. And personally, I have seen cases where these flares come up and as Mr. Prince said, they become fatal because people assume once they take the drugs for 6 months that they are cured. They don't know that certain viruses are there somewhere where the drug cannot reach, and it can, maybe if their immunity is low, they can get reinfected. So I think that part of the information is not there. So I think that just goes to buttress why we should have forums like this to improve our education and to see what we can do to provide better services. For us in Kaduna, in the hospital, I know that in my early days of practice, we used to use lamivudine because even it was provided a DRF program from the agency. But I know over time with practice, tenofovir came in, and then we knew that it was tenofovir. The only thing is that maybe you now have a patient in who has a relative who is in the facility. They now feel, oh, there's free tenofovir lamivudine, but it's in combination. It's in combination. It's not a single drug. So sometimes you have to educate them and say, but the problem is resources, resources, resources. So like prevention is really better than cure. But even when you are infected, you should know what you should do so that your prognosis will be good. If we don't have any more questions or comments, I think we'll round up. But before we do that, I would like Mr. Prince, you give your contribution. Then Pharmacist Jamila will give her closing remarks. Farm Ebon, your hand was raised earlier, but I can't see you. So after close, thank you. So Mr. Prince, you can go on.
Okay. Yeah, thank you very much. So I just wanted to just bring this in now that last year in Geneva, there was this global pledging to have tenofovir, price slashed to terror coordinated by Chad in Geneva last year. So now countries can access tenofovir at global pricing. You observe that tenofovir here, I think the average, we did a survey recently, the average cost of tenofovir is about 16,500 per month supply. But if countries and then subnational governments can put resources together and then access this global pricing, that will greatly slash the cost. Like what we're doing now in Delta states, none of our facilities, none of our hospitals have tenofovir mono formulation. We only have tenofovir lamivudine in the HIV programs, that's the heart centers. But this cannot be accessed by people living with hepatitis because of the strict programming for HIV at the moment. So what we were able to do was to assess this global price, and then now instead of the 16,500, with the access price now, it's landing now at 6,000, which is what we are giving to patients. So pharmacists can also fill this gap. States that have functional drug management agency, or the DRF, can now begin to speak to the government in this regard, that we need to assess this global price so that they can have these medications available for patients who really need that. Pharmacists can do that. And so that's just one way pharmacists can really function in the viral hepatitis space. Again, thank you very much.
Okay, thank you. Farm Ebon, are you going to come up, or should Farm Jamila give her closing remarks? Okay.
Okay, I'll just thank you very much. Let me just first appreciate everybody. I think after that she could just give her closing remark and then you round up. Yes, it's really been a very wonderful presentation. I decided to just stay down in the background today, and really it's been very educative. I know everybody here has actually gone with one note, at least something. And I really want to appreciate the speaker for today, the presenter for today, Pharmacist Jamila. Thank you so much. Really appreciate you. Thank you, Mr. Prince, for joining in. I've been trying to see from where did you come in. Was it from the CPAN platform, from the college platform and all? I think I've asked for your number. Please, if you could just drop your number. I think I saw in your DP you have Hepatitis Foundation. So I think probably specializing in that area, or that's really your field. Thank you so much for the additions you were able to add up today. And truly, if we could just get that funding, because that's really been the problem. I've been in the HIV program for a while now, and we've had people having to crop in. Some even take the risk of having to take the tenofovir, lamivudine together, hoping that since they know you could either take either lamivudine or tenofovir, they'll tell you, okay, maybe they'll take half the dose. But we try to educate them that that's not possible. But because of the cost, and some of these drugs are readily not available. So there are really a lot of challenges there. So like we said, one take home we're taking up today is prevention. So how much we could really spread on to ensure that we tend to ensure people avoid just even getting infected at all. So they don't get to the point of trying to even get the treatment and all. So thank you so much, everybody, for joining in. I really appreciate all. Sipan Kaduna State is saying thank you. We had people around the country join in. Thank you so much. Really appreciate. Thank you, our presenter today. Thank you so much, our moderator. You did a wonderful job. I really appreciate you. God bless you all. Thank you, everyone. Thank you.
Thank you. Pharmacist Jamila, before your closing remarks, please, in the chat, someone was requesting for the slides and they dropped their email. I don't know if you saw that chat. Olumide. So the person is requesting for the slides. So you can go on with your closing remarks. I can't hear you. Have you unmuted? We can't hear you. It's like you're muted. Okay.
Thank you, everyone, for joining in. I'm glad I was able to be part of this interactive session. Thank you to all you guys, Famziri. Thank you for your contribution, to Farm Prince, to all those that interacted, those that sent their messages via chat, and those that attended the presentation. Thank you, and God bless. We've really learned a lot. So we are going home with some mindsets now to, if you're in a place that you can try to push for funding for anti-hepatitis drugs, please, you can start doing that now. You can start advocating for that now. Then for the campaign programs too, as Famziri said, prevention is better than cure. We can be able to start doing the campaigns. 1 or 2 pharmacists just stand up one day, go to one local government, give them that education, make them aware of these infections and how to prevent themselves. Thank you so much for joining me.
Thank you very much. So we would end with closing prayer in our various faiths, and I would give 1 minute for that. After that, we'll close for this.
Sorry, for the person that wants the slides, please, you can contact Farm Ebu. She'll send me.
Okay, thank you. So we'll close after the prayer. Thank you everyone that joined, and thank you especially to those who have stayed till this time. We really, really appreciate your time, and God bless you also. We'll pray for 1 minute, then the host will close the space. Thank you very much.
Amen.
Amen. Thank you.
Thank you, everyone. God bless us all. Thank you. Thank you, Famziri. Thank you, Fam Jamila.